Share. Okay. Can everybody see it?
Yep.
Yes, I can see it.
Okay. So I'm going to be presenting on the ASAM criteria. And the reason I chose this topic is because for the last couple weeks in seminar and didactics, I've heard a couple of clinicians have mentioned that they are working with clients with substance use disorders. And so I worked in a residential addiction treatment center last year, and I found this tool to be very beneficial when working with this population. And so I wanted to share this all with you today to see if maybe this is something you would also potentially want to use. And so the little bit of the outline of what I'm going to be talking about today. So getting into a little bit of an intro as to what the ASAM is, going over the 6 dimensions of the ASAM criteria, looking at the levels of care that are in ASAM, and then also lastly, how do I apply the ASAM within the private practice setting? So intro to the ASAM. So first and foremost, what is the ASAM? So ASAM stands for the American Society of Addiction Medicine, and this is a group of medical professionals, mental health clinicians that specialize in substance use. And they formulated their group in 1954, and their goal was to help improve treatment outcomes when working with patients with addiction. And so this group formulated a guideline slash assessment in 1990 to help assess and treat individuals with substance use. And there are currently 4 editions right now, but the fourth edition, which was came into effect in 2023, is still under review by the Department in Health and Human Services to ensure that all of these, the new dimensions that are kind of being under review are going to be effective. And so the ASAM is used with adults, but they wanted to expand it to be able to apply this to adolescents and trans age youth as well. They also wanted to adapt this for individuals in jail and in prisons. And then lastly, since the ASAM targets substances and with addiction, there are more than just substances, there's other forms of addiction. So they wanted to expand it to include gambling, internet and gaming, as well as sex addiction to make it a little bit more diverse. And so it is a multi-dimensional guideline that utilizes more of a holistic approach, which is what those 6 dimensions kind of takes a whole view and picture of a client's presenting substance use concerns. And so, which I like because I like to utilize holistic therapy with my clients, really getting the whole picture of the client to see what's really, leading to these presenting issues. And so, why does the ASAM essentially matter? And so, it helps to ensure that the clients are receiving the right level of care. And that's the levels of care is what I'll be touching on a little bit later within my presentation, as well as it also helps to improve treatment outcomes when working with clients with substance use and addiction. Third, it helps to facilitate treatment referrals, and that gets into after when you go through the dimensions, doing kind of the little bit of ratings, you start to notice what level of care does my client fall in, and then that's where the treatment referral process would come into play if you notice that they might need a higher level of care. And then lastly, it is used by insurance companies. I know in a residential setting, this was a main form of how clients would, insurance companies would determine how much they would pay for treatment for a client to stay within the facility. And so it is pretty viable in a client's treatment process. So what are these 6 dimensions? So I listed the third edition as well as the fourth. There are some similarities and a little bit of differences. And so overall, the main things that they assess for is like acute intoxication as well as withdrawal potential. They look at the medical as well as physical health of the client, so the biomedical conditions and complications. Third, they look at the overall psychiatric conditions of the client, so their emotional, behavioral, and cognitive conditions and complications. And then in the third edition, there's a section for readiness to change. So that's where that stages of change model comes into effect to see where the client might fall. They're in pre-contemplation, contemplation, preparation, action, and so forth. But in the fourth edition, this is interwoven throughout the whole thing. So there's not one section dedicated just for readiness of change. And then for the fifth one, it still assesses relapse potential. And then lastly, looking at the client's recovery slash living environment. But in the fourth edition, the last dimension is a person-centered consideration. So really working with the client to kind of help um, work collaboratively to help achieve their goals overall. And so since the fourth edition is still under works, it's recommended by the American Society of Addiction Medicine for clinicians to continue utilizing the third edition when working with clients with substance use. And so that's the six dimensions I will be going through with you all today. So for dimension one, this is the acute intoxication and slash or withdrawal potential. Since I do have access to the third edition, I thought it'd be beneficial for you guys to see potential like questions of how it's laid out, just to gain an idea of what am I actually like using with my clients. And so since it's a pretty lengthy assessment, for starters, before even sitting down with my client and doing this, what I like to do is our clients fill out intake forms and as well as like history information. What I like to do is take both of those documents and start inputting some of that information throughout the dimensions, just because some of those questions are asked. But I like to put those in the notes, and then if I get to it and I want to probe a little bit further to gather a little bit more info with the client, I will do so. But if the client on the intake or history form answered it to its extent, then I might, skip over it. But at least I have that information there with me. And so for that first dimension, this really addresses any potential intoxication levels or any withdrawal potential symptoms that they might experience. And so they go through gathering their substance use history in depth. So it lists a bunch of substances that to ask the client if they've ever used it, how long they're using it, how frequently are they using it, and also the route of administration. And so here's just a couple of options. There's more listed. They address cocaine slash crack, methamphetamine slash stimulant use, uh, prescription misuse, because I know here it's prescription opioid misuse, so they address other forms. Nicotine or tobacco, and cannabis and marijuana is also listed. And then there's an other section. So if a client comes to you and discloses they are using substances that are not on this list, you're able to write it down, but still are able to assess how long, their frequency, and their route of administration, just to give you a full picture. Because route of administration, taking psychopharm, each one gives off different effects. And knowing oral is the most commonly administered route, still oral compared to intravenous or intramuscular are very different in their effects. And so being aware of how your client is using the drug is also very valuable as well. And then I've chopped a couple of questions. I won't read every single one, but just to kind of give you guys an overview of what you might be asking. And in the corner, they emphasize like using inner motivational interviewing skills to kind of help, you know, figure out whatever the client is saying and, getting your own assessment of their problem as well. So that's subjective and objective, observations. And so one of the questions that they would ask would be like, how much are they bothered by any physical or emotional symptoms when they stop or reduce their substance use? So are they getting any body aches, nausea, anxiety, maybe some depression? So assessing any physical as well as mental health withdrawal symptoms. And then are they currently experiencing any withdrawal symptoms as of now? So you have a client that comes into therapy mentioning to you, I stopped drinking maybe a week ago, right? Currently assessing, it's been about a week. Are you experiencing anything now in this moment, like as you started to stop your use? And then going into like assessing any tolerance. Have they increased their use to get the same effect? And then also getting that history if they've had any serious withdrawal symptoms or life-threatening symptoms when they've discontinued their use in the past too. And then also if they have a potential history of overdose, which is very important to know, just because if you are working with a client that does have, severe addiction, what are the ramifications? What is your history and background, just so that we can prepare for steps moving forward. And so, but, and then the right side, or the right side, at the end of each dimension, they have a problem statement and a goal section, which helps you for your treatment planning purposes. So they kind of summarize and put a couple of the problems within the questions, and then they have a goal at the end that you and the client kind of work with to formulate to kind of help navigate how are we going to go about our treatment. And so for the first two, it's do you have any concerns about risk for overdose as well as for withdrawal? And so if the client actually checks off no and no, okay, you could put NA. But that's again, for my knowledge, just to be fully aware I'm checking every area of that. And then if they have any concerns about potentially getting medication like naloxone, Suboxone, stuff like that for treating their withdrawal symptoms. And then through that, what is their goal to help manage withdrawal if they do experience it or potential risk for overdose? But again, if the client is good, checks off that they're not, we don't have to make that as a goal. And so with the not at all, a little, somewhat, very, and extremely, you see that there are different colors. And these colors matter because this at the end, which I'm about to show you, is what kind of helps determine their severity rating. So if they put not at all, that's the green. So there's no signs of withdrawal or intoxication present for the client. So they essentially would get a 0, that this section is good. My client doesn't experience any of this. But if you start to notice, okay, my client is falling into different categories, they give little points to help you also kind of determine based off of the subjective feedback that they're giving you, where is my client falling in this range? And these numbers 0 to 4 are very important when I get to the levels of care and where, like, if the client needs a higher level of care based off of the ratings that are given in each dimension. And so, like a 1, there might be some mild, moderate intoxication, and that their substance use interferes with their daily functioning. There's minimal risk of severe withdrawal, but they're not in danger to themselves or into others. And so it gives you little pointers as to what things could you work with to kind of help manage this as well. So withdrawal management, following up with them, moderate, same thing, might have severe, but responds to support, moderate risk to severe withdrawal, no danger to self and others, stuff like that. And then within dimension 2, this is the biomedical conditions and complications. So the first thing is assessing their medical and physical health. So if they have essentially asking that question, do you have a primary care condition that kind of helps you manage your medical concerns? On the intake form, sometimes the client mentions that they do and also lists their medical/physical health medications. And so this is the information that I would transfer over, but I would also probe further to see maybe they left something off on the intake or the history form, as well as kind of getting some notes as to maybe their thoughts about their medications and how they might feel about it. Second, so this is more of that self-report scale, still using those areas. So addressing if any of their health issues listed above that they've disclosed to you, if that's interfering with their ability to maintain their ADLs. So getting up, showering, eating, doing housework, all of that good stuff. If these health issues are making it harder for them to attend work, if they do happen to go to school, engage in hobbies, interests, stuff like that. And then if these health issues make it hard to attend substance use treatment or potentially stay in substance use treatment, and then if they have an individual in their lives who can help support them with their health issues. And so they have a little point. So even if they don't need help, so in pre-contemplation, I don't need help with this stuff, do they essentially have a support person in their life? And you're able to have a little section to further write down all of this information. And then those problem statements and goals. So does the client have any concerns about their physical or health or any medical conditions that they're experiencing? Do they have any goals that they want to work on for this as well? And so number 19, this is up to your discretion. It's whether or not the information that they disclose to you, are these considered to be life-threatening or they require immediate medical attention? Just because if they do have a lot of, physical or medical conditions and they're chronically using substances in this interplay, could this be life-threatening to the client or result in like needing immediate like medical attention to kind of help? And so having that background there. And then again, based off of what you get from that 0 to 4, where would the client essentially fall within these categories? And so they might have some mild symptoms, but they're able to function normally and they're able to cope with their discomfort. Or, their substance use is kind of getting in the way in conjunction with their medical/physical health. But they're not life-threatening. They just aren't able to maintain ADLs. They don't have too much of a support system. How can we go about, working this into our treatment plan? And then dimension 3. So this is the mental health section. And so there's a good amount of questions within this, but I wanted to just kind of pick and choose a couple of them just to give you guys an overview. So for number 5, they do address trauma and abuse history. And so if they've ever experienced any abuse, physical, emotional, sexual, as well as mental and emotional, or any other traumatic events in their life. The client has the option to say yes, no, and or skipped. And again, you further probe just because it has those direct yes or no questions. Definitely probe to see if they're willing to disclose this to you if they did not do that already within the intake or history form. And there are note sections on this document to be able to write this out if you would like, or if however you guys take your notes on a blank piece of paper, you have that information with you just to see if there's a connection too. And then this is where you would write their medications for their psychiatric conditions and transferring that over. And then they also have a section, even though marijuana and cannabis was listed on the substance use history, they do ask if they potentially use marijuana or marijuana related products like CBD or the extracts as a medicine for any psychiatric conditions. And here in California, recreational and medical cannabis is legal. Some clients might, use either or to treat their mental health symptoms. And so by addressing that right then and there kind of helps to get a little bit more details. And then another section, so they list a bunch of different mood symptoms and they address, within the last month, which is more recent, but again, our clients might be coming in with lifelong depression, stuff like that, anxiety. But just for you to understand within the last month what they have been experiencing, they've been experiencing any of these types of symptoms, or differentiating between, are you only experiencing these mental health symptoms when using or withdrawing from substances or other drugs, which is a big differentiator to see if when they are using or not using, are these more prominent in the client's functioning? And then other questions. So they do assess, psychosis. Do they ever hear or see things that other people say they don't see or hear? And also they risk assess for suicidal ideation as well as intent, as well as homicidal ideation and intent. So have you ever had thoughts of hurting yourself? Thought you'd be better off dead? Are you having these thoughts today? Have you ever acted on these feelings to hurt yourself before, as well as thoughts of harming others? And so within those problem goals, it's looking at like what concerns or worries do you have about getting treatment for your mental health problems? So client coming into treatment, do they have any concerns about going through the therapy process and like what might be causing that? And then any goals that they have. So taking that problems, the presenting problem on that intake and putting it right there, but also probing a little bit further. What goals do you have during our time to work together? Then again, going back to that mention rating, so 0, no dangerous symptoms, good functioning, self-care. Symptoms are not interfering with their recovery process, all of that good stuff. And then looking at the bottom to see what route could I potentially go with this. Dimension 4 is that readiness for change. So this is really assessing where does the client fall in that stages of change model. And so all these aspects, domains of a client's life that they could be engaging in, it's essentially asking, do substances interfere with any of these? Do they interfere with your inability to work, go to school, with your mental health, your finances, friendships, physical health, etc. And then asking them, do they believe changing their substance use could improve any of these aspects of their life? Do they think that they need treatment to change their use of substances? And then assessing how much is substance use a problem for them? Have they done anything in the past to try to change their substance use problems? And then they also have like examples of the client may not understand. They have a couple of options to kind of help probe to see, have you tried any of these things before? Have they attended treatment in the past? And then are there any concerns or fears that make it hard for them, to go or to stay in treatment? And then when assessing other social supports too, how much do your social supports care about you quitting or cutting back on your substance use? And how important is it for you, the client, to make changes in your life at this time? And then how ready are you to sign to stop or reduce your substance use as well? So really just getting direct and straight to the point. And then those problem statements. So the problem, are there any concerns you have about changing your alcohol or drug use? Are there things in your life that you would like to be different from how they are now? And if so, if things were better, what would that essentially look like for you? And so these models still kind of follow that stages of change to see where the client might be falling. And then dimension 5, which is relapse continued or continued problem potential. So this really assesses potential relapse. And so really looking at what's the longest time the client has gone without using substances, how long ago was that, what helped them during this time to stop using substances, and then if they have relapsed in the past, what kind of things, starting to formulate and think, what kind of things do you think the client led you to kind of relapse in the first place? How will you manage, planning to cut back or quit? And as well as number 6, this is for your own observations, like how severe or dangerous or imminent are consequences of the current situation. So if the client has a high relapse potential, are there any, immediate or concerning consequences that might come from high relapse rate? And then also looking at potential triggers. And then with these triggers listed, if a client also has other triggers that they've disclosed, they're able to write that in number 13. Assessing how do they essentially handle these triggers to kind of cope. And then if they feel like they have a good plan or ability to kind of deal with these issues or triggers. And then lastly, so that problem, what are the current most pressing issues that might cause you problems or cause you to use alcohol or other drugs more than you plan to? And the goal to kind of help work with them. What would it look like if those issues were resolved, and what would it take to essentially resolve them? And then back to those ratings. 0, low potential / no. 4, no coping skills. Their substance use places in self-harm to others as well as to themselves, stuff like that. And lastly, the dimension 6 is the recovery / living environment. So this goes in and outs of to where the client is residing, what their environment looks like. So addressing like, do they need different housing than what they currently have? Because if they're in a household where there's active users as well, drinking or drug users, this could also probably impede the recovery process for them if they choose to also want to stop, making a little bit more of a challenge. Also, who do they live with? Family, friends, partners, roommates, etc. just to gain an idea. And how are those relationships with these individuals? Are they currently working, going to school? Are they retired, unemployed, disabled? What's their means of financial support? Are they actually engaged in any social services? Do they have any legality issues related to alcohol or drug use? So any potential DUIs? Um, and have they ever participated in any peer support groups before? NA, Smart Recovery, Women's Recovery, SOS, stuff like that, just to get a full picture idea. And then these two I find to be very important when working with clients with exhibiting SUD, such as what are some supportive people, places, and things in the client's current life? And then what are some people, places, or things that make it challenging for a client to quit or cut back on their substance use? So being able to have a list that's in your face. All right, this is the support, and then these are some things that I need to be aware of. And how can we help navigate or manage this if these people, places that you go to, or things come up for you? And then, so some of the problems. So, really asking the client, what changes are you willing to make to support cutting back on your substance use? And what are some changes in your work at home that you're unable or unwilling to make to help support? So, really kind of getting to the nitty-gritty of what they're willing to change and what they're not willing to change. And then looking at if things improved in your environment, what would that essentially look like for you? And then again, that severity rating. So with the one, two, three, and four, this is where I will be getting into the levels of care. So what are the levels of care in ASAM? So there's four levels. So level one is outpatient. So the private practice, this is the one that we're currently in. So this is less restrictive and it's about less than 9 hours of treatment per week and it has less severe symptoms. So I know some of us might see our clients one, two, or three times a week, so that would fall in the outpatient, category. Whether even if it's not substance use, we still see our clients frequently, but we might not see them 9 hours per week. So if a client needs a little bit more therapy, that's where they move up to level 2.1, the intensive outpatient, which offers mental health as well as substance use counseling. And this is at least 9 hours, but no more than 20 hours of treatment per week. So this is where a client will go in, have multiple therapy sessions. They can do telehealth, and they also have access to medical care 24 hours by the phone if anything comes up for them, as well as 72 hours in person. And then the client needs a little bit more. Level 2.5 is a partial hospitalization. So this is 20 hours of treatment per week, and it's structured in daily monitoring, but it's not 24/7 hour care. So this essentially means the client would go to treatment for maybe 4 or 5 hours throughout the day and then be able to come home at night. And they would do this throughout the week. And then maybe a little bit more, 3.1, that's that low intensity residential, which is considered a group home. And this is the type of setting that I actually worked in last year. So clients needed about 5 clinical service hours, which was obtained through meeting with their therapist one-on-one, um, and also attending group therapy throughout the week. And their main focus was on relapse prevention as well as emotional regulation skills too. And then 3.3, it's a specific high intensity residential. So this is more so same rules, you're learning relapse prevention and emotional regulation skills, but it's at a slower pace and it's designed for individuals that might have a TBI, more so for the older population, as well as developmental disabilities, just because of the structure of the facility. I know I have worked with some clients that had some developmental disabilities as well as the older population in that 3.1 residential, but the structure of how it was kind of built was not considered safe for these clients, and so we had to move them up and recommend moving them up to a higher level of care to ensure that their physical, health was also, taken into account and assessed. And then 3.5, so the high intensity residential. So this is where you also have comorbid substance use as well as severe mental illness as well as social issues. And then these clients are in imminent risk to harm to themselves as well as to others. and they are on a 24/7 oversight. And then with level 3.7 and level 4, they're both intensive inpatient units, but the difference between 3.7 and a 4, 3.7, they don't need to interact with their physician on a daily basis. Compared to a level 4, they need to have like constant, daily interactions with their physicians for evaluations, check-ins, and so forth. And they do also have 24-hour nursing staff to kind of help manage medications and stuff like that. So within these levels, how do we apply the ASAM within our private practice setting? So first and foremost, what I like to do with clients in general is screening tools. So the GAD-7, PHQ-9, but specifically with substance use, I like to use the audit as well as the DAS-10 because this gives a pretty good overview and an idea of where the client's symptoms might fall to give like an objective number. And I like to give these at the beginning, middle, and end of treatment, just so that I can check progress to see if that, number is staying the same. Is it increasing or is it decreasing? So using those screening tools along with the ASAM information essentially gives you a fully comprehensive assessment of how do I go about creating a treatment plan with my client and what are we going to focus and work on together. And then also with ASAM, so this is whenever we're going through it, we get a client coming in and, you go through this and they're like, my client might need a higher level of care. So how you kind of go about this in outpatient. So a level 3.1 to 4.0 is that residential slash inpatient. So this is whenever you notice a client cannot maintain sobriety in an outpatient setting due to environmental risk or severity of addiction. And the severity of addiction, I'll get a little bit further into on the next two slides. The level 2.5, client needs structured treatment, but they're able to function out of an inpatient care. So they're able to continue going through their daily life, but they need more treatment, like structured in a lot more hours of treatment than what a outpatient service could provide. As well as 2.1, they need multiple therapy sessions weekly to stabilize. Remember, that's at least 9 hours of therapy a week. And then if you notice, I need to refer my client to a higher level of care. How do I do this? So discussing the need for a higher level of care based off of, your clinical observations, your clinical judgment, if that's what it's telling you, based off of your time together, and using that person-centered, client-centered approach, being collaborative as well as non-judgmental when approaching this. Also providing multiple referral options, so checking to see if their insurance will even cover this. I know within our practice, our insurance is Medicare, so I looked up what Medicare would actually cover if this is something, one of us may have to do for one of our clients. So for Medicare Part B, Medicare will cover inpatient services, IOPs, the intensive outpatient, uh, PHP, partial hospitalization services, and behavioral health integration services, which is like community mental health as well as residential. And so when looking after the client pays their deductible, Medicare will cover at least 20% of the cost if the client chooses to, enter any of these facilities too. And so for Medicare, I just wanted to include that just in case.
So it covers up to 20% of the cost.
Yeah, they have to pay their deductible first, and then they'll cover 20% of whatever their
Because
services
these
offered.
uh, places generally pretty expensive,
They
and
are.
having to cover
Hmm.
80% may be a real burden.
Yeah, for sure. And so being open and transparent with your client about that as well.
Yeah.
So there's ethical consideration and risk management. So with the general principles, so really when you're noticing my client might need a higher level of care, using, recognizing beneficence and non-maleficence, fidelity and responsibility, integrity, justice, and respect for the person's rights and dignity all come into effect with this, as well as three ethical codes. So 2.01, boundaries of competence, 3.04, avoiding harm, then potentially 10.10, terminating therapy. So with the first two, 2.01 and 3.04, when doing research and also when doing research on working with substance use disorders, it was recommended that you should not treat moderate to severe substance use without specialized training. And I recall Sammy brought up one ethical question about client has substance use and you notice that you want to refer out. Do you continue working with them or not? And you essentially refer them to a substance use specialist. But if the client also has underlying like anxiety, depression, PTSD, OCD, other forms like that, you're still able to help treat that. But if the substance use is out of your own like boundaries of competence, it's our ethical duty to refer out to get them to receive that higher level of care. And then also, in turn, that avoids harm for the client. But again, if you do have that specialized training, you're able to do that within an outpatient setting. And then if your case is considered mild, like their substance use would be mild symptoms, just continuing to seek ongoing training, staying up to date with research to ensure that the client is getting, the best optimal care possible. And then what if you go through all this process, you tell them about, noticing that they might need a higher level of care, give referrals, and the client refuses? What do you do? And that's principle E, like respect for people's rights and dignity. So you have to respect the client's, autonomy in this situation, unless again, it's they're an imminent threat to harm to themselves or to others. That's where, that confidentiality kind of breaks in and having to take that step. But ultimately, the client has the right to refuse even going to treatment. And so if they do, documenting really, and I know we just mentioned like what do I even document in these notes, but it's still ideal if you're noticing, you could be broad in your notes that based off of, my time with the client, it appears the client needs a higher level of care, provided multiple referrals, client disclosed that, you know, they don't want to use these referrals, something like that, just to ensure that you went about the right way. And at the end of the day, the client, gets to decide what to do with that. So to end this presentation, I found this quote that I thought would be very beneficial. It's by Carl Bard, and it states, though no one can go back and make a brand new start, anyone can start from now and make a brand new ending. And I thought this was pretty powerful when working with clients with substance use, as well as just working with anybody in therapy in general. And it kind of reminded me of what you say, Dr. C, about scene work, where how you tell clients, like, I wish we can go back in time and take that time machine, but, it's not possible. But through scene work, this is the time and this is a time to like start your emotional healing process and in turn that like starts to make a brand new ending and chapter for this story for the client. And so I thought this quote would be applicable when talking to or mentioning to clients with substance use, but anybody kind of just starting therapy. Like we can't go back in the past and make a changes to what happened, but we can start now and make a brand new ending. And also with redecision, that brand new ending is now being able to kind of help make a fresh new start.
Well,
That is my presentation.
how long does a ASAM take to administer a full one?
I would say about like 30 minutes, 20, 30
Really?
minutes. Yeah.
Wow. Just seems like how many total questions about are we talking about?
Um, so each section might have like 10 or 12, but some of the clients, like you'll notice, they might want to disclose a lot, or some clients are just not open to really like disclosing in depth. So that also takes into consideration that timing piece. I've had clients, some took as little as 20 minutes to do the whole thing with. Other clients took maybe 45, 50 minutes to do the thing if they wanted to spend some time talking. And so it's just essentially a guideline for your own knowledge as like a toolkit to use if you have a client with SUD and you want to gather or ask maybe more detailed questions when working with them for your own knowledge as to, our treatment time together and stuff like that.
How available is the ASAM? Is that something we can just pull off as a PDF, or do you have to buy packets of them?
No, I have the PDF and I can upload it to the PDF, the interview guide for you guys to
Put
utilize
that
if
in
you
the
wish.
assessments folder, please.
Okay, I
And
got
could
you.
you put the this PowerPoint in the didactic folder, please?
Yes,
Both
I
are
can.
important. Um, Anybody else have any questions?
So, hi Natalie, thank you. That was great. Um,
Thank you, Dr. Vin.
so, you're administering this face to face with an
Mhm.
individual subject. They're not doing anything online or in a group
Mm-mm.
setting. It's all face to face, and you're writing down their answers with a pen. Is that how you're administering it?
Yes. Yeah, in person, meeting one on one, and just going through the assessment and gathering as much information as you can. And then if you want, you can also have your own piece of paper to take some notes down as well. Doesn't all have to be on the assessment.
Do you generate a separate written report then based on it, or do you just submit what is it that you file in the patient's file? Is it just the form filled out, or do you also generate a written report?
So in the residential setting, I had it on my computer, and so this is had more detailed. So you basically choose the level of care based off of that, since the client was in residential, and if we were in a 3.1 setting, so if the client needed a higher level of care than 3.1, you make the justification as to why they might need a higher level of care through all of the dimensions assessed, taking their quotes, your clinical observations, stuff like that. And then at the end, all of those treatment planning goals, you essentially formulate like what plan do you have for the client during their time in treatment? And this for residential insurance company looked at all of this information to determine, okay, based off of what the clinician is stating, how much time are we going to pay? Like, how much are we going to pay for the client to stay in treatment? We're going to pay for a week for them, 2 weeks, 3 weeks. And so in the outpatient practice, this could be like a guideline since the ASAM probably won't be. I can look a little bit more into that if the ASAM would be covered by insurance within a private practice. But essentially, it's recommended when looking at research for clinicians to use this when working with substance use, so that way it can give you a real holistic overview of their presenting issue as well as any comorbid mental health symptoms that they are experiencing. So this is more of your guideline. And, when you're noticing, okay, going through this, if my client is getting threes, what are the next steps that I should take? Maybe potential residential might be a good recommendation. So recommending a recovery program on top of, their treatment and stuff like that.
And
That's
that
where that referral
recommendation
comes
would
in.
come in the clinical notes, so you'd attach
Hmm.
a copy of the finished ASAM, and then you'd have your clinical notes that have recommendations, basically.
Yeah. Yes.
Yeah, I get it.
So, are you filling it out online? Do you have a fillable document that you're typing in online as you administer it face to face? Is that how you did it?
So it was within our electronic health system. So we used Kipu. And so Kipu had a ASAM tab that when you clicked it, it was all there to where you could like type. And then they had the selection for, what dimension. So those 0, 1, 2, 3, 4. At the end, you would just select which one based off of your clinical observations, as well as the subjective feedback the client gave you. And at the end, another drop-down menu where it would tell you, so based off all these, where do you think the client might fall? And then they would have a justification box where you had to type all that information in, really bringing in all the dimensions to make your case, and then writing that treatment plan. And
It
then you
sounds
would
like where you
sign.
did it, it was integrated into a bigger system. Is that
Yes, just because, yes, it was. Just because that was the way that client, it would help determine whether a client or not could stay in treatment with us. And so for a private practice setting, they recommend just using this guide for your own knowledge to determine, okay, I'm noticing my client may need a higher level of care than what an outpatient private practice might be able to kind of, offer them in this moment. Maybe recommending a higher level of care, like a recovery program, might be the steps to do and having that conversation. But if you notice going through this guide, my client is falling in 0 to 1, then we're okay. We can still manage and work through, the substance use issues that a outpatient setting can provide. That helps.
Well, it seems to be an abstinence-based model as opposed to a harm reduction model, because the criteria is whether the person continues to use the substance.
Yeah. And so then that's where I was located at too, was an abstinence program, not a harm reduction model. And so,
Even
but
though they use aspects of the motivational interviewing, it seems.
mhm.
It does
And there are
seem to be abstinence based.
yeah, but there are some questions like to stop or reduce your substance use. So other facilities, if they, are harm reduction and, what can we help kind of reduce the use versus like if you want to remain abstinent as well.
What was the facility where you were working?
Akua Mind and Body.
Is that in Sacramento?
Yes, it's actually on Sunrise over here. So there's many different locations throughout California, but it was in Orangevale, I believe. Orangevale County over here. Maybe it's like 10-ish minutes away from the Gold River location.
Yeah, I know Orangevale. I think that's in
Mm-hmm.
Sacramento County,
Mm-hmm.
Yeah.
pretty
Okay,
sure.
yeah. Okay. Yeah, then Sacramento.
Okay. Anybody else with any questions? Thank you, Natalie. That was very professional as usual. Uh, Appreciate
Thank you.
your expertise. You've actually been through this stuff and have dealt with clients with it. Um, uh, Sammy or Pamela, do either of you have any questions or comments?
No, I don't.
All right. I think I'm going to let you guys go then. Pamela, stay on the line, please.
Yes.
Everybody else, have a good week. We have normal weeks now. Everything is as scheduled.
Cool.
Thank you,
Also,
Natalie,
Dr.
again.
Okay.
No problem.
Chris,
Um,
thank you for offering to cover for me in my
Okay,
absence. Thank you, but I will see you next week.
good. All right.
have a good trip, Dr. Ben.
Thank you.
Um, Dr. C, you're still recording, letting you know before you hop on supervision.
How do I? The record button went away. There we are.